All right, you guys ready?
Does this mic still work?
It does.
Okay. Okay, I'll just put it back. Alrighty, good morning. So I have the privilege and the honor of introducing our speaker today. So today we're going to have Dr. Clark Noble. He was born and raised in Northeast Georgia, completed his undergraduate degree at the College of William and Mary with a Bachelor of Science in Neuroscience, and was a 4-year conference finalist in swimming. He went on to complete Marine Corps, OCS, and Navy Flight School piloting, and I think he thinks this is cool, like we're going to understand what this means, but piloting the CH-53E Super Stallion as part of the HMH 462 squadron at MCAS Miramar, yep, okay, for one deployment during the 15th Marine Expeditionary Unit and 2 deployments supporting Operation Enduring Freedom in the Helmand Province of Afghanistan. He also, fun fact, competed in 2 all-armed forces triathlons as part of the Marine Corps triathlon team. Like, no big, energy there. And he then went on to attend the Medical University of South Carolina with a Navy HPSP scholarship and was involved in community, veteran health, and military medicine within that institution. I heard he also got a degree in Surfer Dude while he was there. His psychiatric interests include posttraumatic stress disorder in the military population and aerospace psychiatry. In his free time, he enjoys surfing whenever possible, competing in the annual Lake Tahoe open water swimming race, reading about Toyota LandCruisers, researching financial planning topics, which he then distributes all of his knowledge throughout our class, which I love that, and spending time traveling with his best friend and wife, Jen, and their dog, Finnley. In the last year, then I've been able to share kind of hallway space and office space with Dr. Noble. It has been an absolute pleasure to be able to have his calming voice and presence in my life, be able to talk about patients, and I think we all can see the passion and compassion he shares for all of his patients and for all of his colleagues. So it has been an absolute blessing to be able to share 4 years with you, and I'm so excited for your talk today. Please welcome Dr. Clark Noble.
Yeah, thank you, Dr. Youngins. That was really, really nice. Wow. So I'm going to talk about the anatomy and physiology of trauma today. I had a couple staff attendings, Dr. Hogue and Dr. Andrade, that really helped me out with this, so thank you for that. So let's go ahead and launch right into it. I can get this to work. It's like my clicker's not working right. Okay. I don't have any disclosures to tell you guys about, so that's a good thing. All right, so objectives for today, I'm going to be reading a little bit while I'm doing this. Is to define what trauma is, identify the basic theory of the effects of trauma on the human body, identify the DSM-5 TR criteria for PTSD, identify how specific neural tracts relate to specific symptoms of PTSD, and then relate why specific modalities of treatment are effective for post-traumatic stress disorder. So let's talk real quick about the word trauma. So I found a Vox article from January 2022 last year stated how trauma has become the word of the decade. A couple quotes here from that article. I have trauma just becomes like I'm depressed or I'm addicted to cookies. It has become a popular idiom tossed around without meaning. By relying on trauma to understand our modern lives, we're undercutting the very real impacts of stress and overwhelm. We're flattening all hardships, complaining they're horrific and life-shattering with the merely unpleasant. Using the word trauma turns every event into a catastrophe, leaving us helpless, broken, and unable to move on. It's a bit of an extreme view on the word trauma, but I thought that was good to point out. So I found another systematic review on the neurophysiology behind trauma-focused therapy modalities. They define trauma as threats to life and bodily integrity, a little more in line with criteria A. They further refine it, though, by this quote. We would, however, add biopsychosocial and spiritual health to life and bodily integrity because acts of emotional, verbal, psychological, and spiritual abuse, among others, also have potential to significantly impact individuals and communities and thus be perceived as traumatic. And there's one quote I found from the end of this article. Again, I thought this was great, kind of a summarization. What we're lacking is language nuanced enough to capture the experience we collectively and individually have. We need new glossaries to describe the human experience. And I think the overall fact that trauma is such a part of our lexicon today is a good thing. We're talking about things that affect our behavioral health instead of not talking about it. However, today we're going to focus on what I like to call big T traumas, and everything else outside that criteria would be little T traumas. So even though it's a good conversation, I just wanted to clarify what kind of trauma we're going to be talking about today. So there's a helpful circle for you in case you didn't pick up on that. And I have a couple videos today, and this is good to kind of hear from patients in terms of their perspective, what it's like in their shoes. And this particular individual is from the Royal Marine Commandos. So let's hear about his story for a second. All right. So E.T. was able to relay his story. So just real quick, I want to point out a couple things about this to kind of define his story a little bit better. So he's in the Royal Marines, which are not like necessarily our Marines, they're more of a special forces unit. OPERIC is what the British called their operations and Operation Enduring Freedom. So 7 and 12 was 2007, 2012. And the Royal Marines were in that Sangin, that region right here. You can see this brown area is where they were at in Sangin right here. That used to be called RC Southwest, so Regional Command Southwest. And then the Sangin is this little nasty little valley right here, just below the Kajaki Dam, where the Taliban had a really significant stronghold. So Royal Marines were there. This is battle unit from 2006 to pretty much into the war, but they were in charge of it from 2006 to 2010. And some of the worst fighting in Afghanistan occurred there. In July of 2010, 3rd Battalion, 7 Marines took over from Camp Helmand. They were relieved by 3-5, so 3rd Battalion, 5th Regiment, in October of 2010. They were there until April of 2011. And then this last battalion, a 1-5, also from the 5th Regiment, took over in April 2011. They were there till October 2011. I had the honor of serving with them and flying in and out of this valley all the time. It's where I got some of this stuff, these ribbons from flying in and out of there. So why do I mention that? That last year combat was the worst casualties that were had by any unit in Afghanistan up until that time. So they took 42 KIAs and 375 wounded in action from these 2 battalions there on the end. So 2,000 Marines had about 25% of them affected physically, or they were killed in action. So when this guy talks about kinetic activity, it certainly was what was going on there. So that's one kind of stereotypical trauma when you talk about military trauma. This is another one I just want to kind of bring light to. Okay, sorry to cut her off her story there, but that's another trauma we regularly see in the outpatient clinic, and I think it deserves light in this conversation as well. So what we're going to do today is we're going to kind of go through the PTSD criteria, and we're going to start obviously with criteria A. Those are 2 great examples there. And basically it's directly experiencing, witnessing, learning, or experiencing repeatedly any act or threat to death or serious injury or sexual violence. So I think we both can agree that both of those individuals had meet criteria A. Let's see if I can click the next one. So does anybody have any good acronyms they use for PTSD criteria to remember it?
Yeah, well, I use Tiana, so.
Okay. Yeah, that's a great one because you might want to recognize the 7 West board. That's Team B. So I was taught that by Dr. Vanessa Freeman, which was one of the former chief residents here. So you go through the different criteria, A, B, C, D, E, and it's 1, 1, 1, and then 2, 2, and then it has to be 1 month there at the end. So this is a great way to remember. I haven't forgotten it. I think Kyrie is here somewhere, maybe one of the med students. Yep. That was me a couple weeks ago teaching him on 7 West. So. And if you don't recognize the red tape, that's Dr. Alan Bell that put that in there when he was a med student. So everybody's paying it forward. So in any case, a little bit more on this. I just wanted to mention that just so as a teaching example. But for today, I went to a PTSD circuit article that given me by Dr. Andrada. So basically what it does is it gives rodent and human models to describe the different criteria. So B, C, D, and E, and what's going on in neural tracts in the brain, which I thought was really interesting. So we'll go through this article today, starting with an example from a patient, kind of like the videos we just saw. We'll look through the different neural tracts and make sure we also understand the criteria while we're doing that. One more plug here before we go any further. So to get all this data, there's a really in-depth article. They use what's called optogenetics in bold and functional MRI for the human subjects. This book, if you're wondering, this old book here on the left-hand side, this is my dad's dissertation for his PhD, because he was a neuroscientist. I'm just giving him a shout out right now. But it's 146 pages, typed with a typewriter back in the day, and he somehow kept like 30 rats alive doing lesions in the ventromedial and ventrolateral midbrain of rats. So thank you, Dad. And now we use stuff like optogenetics, and Dr. Kruger actually has Dr. Nick Kruger, second year PGY2, actually has an article that he's published on this, a study. He was telling me about it yesterday. But optogenetics uses engineered photoreceptors that are genetically introduced into cells. Cells that are naturally light insensitive can be made photosensitive, and light is utilized to precisely control functional parameters like membrane potentials in these cells. And I asked him, he said, this is a good way for a layman to say this. You basically can turn cells on and off with the light. So I don't know if you've ever seen it. It's a rather gruesome looking fiber optic cord going into a rodent brain, but this is how they got some of the data. So BOLD and fMRI, that stands for blood oxygen level dependent imaging. So cells that are neurons that are active obviously use more oxygen. And then the hemoglobin signature is magnetic, so it picks it up, and that's how they got the data for the human subjects. So just wanted to shout out to my dad and then kind of point out how they got this data. So don't go crazy. This is just a picture of a brain, but I just wanted to go through a little bit of anatomy here before we start, because when we talk about PTSD, we're talking about the limbic system and its relation to the rest of the brain, especially the frontal cortex. So it's made up of the hippocampus, amygdala, hypothalamus, cingulate cortex, and thalamus. Notably, I'm probably leaving some things out. This is rather brushing the surface of all the data here, but the hippocampus itself is involved in the formation of long-term and spatial memory. So it takes short-term to long-term. The amygdala, which you've all heard of, assigns both positive or negative value to stimuli, identifies threats, starts the flight or fight response, and is involved in the emotional component of memories. The hypothalamus is basically the link between the endocrine system and the nervous system, at least one of them, by releasing hormones. And then the cingulate cortex, in particular, the anterior cingulate cortex, this blue part toward the anterior part, is involved in assessing the salient, so the positive or negative value of emotions and motivational information, especially when there's effort and motivation needed to carry out a task. And then the thalamus is a relay system, more or less processing all the body senses except for smell. And sends it, before sending it to the insula and cerebral cortex for interpretation. So I hope you guys aren't too bored with that. One more structure, the insula we'll talk about today. Insula is involved in interoception and receives inputs from the thalamus and the secondary somatosensory cortex. So that first part of the parietal lobe. The insula is involved, like I said, in interoception, but interoception is bodily awareness, such as a sensation of hunger, thirst, cold, warmth, like tense muscles, a rapid heart rate. So a properly functioning insula will be able to tell you in any moment, like, how do I feel in my body right now? That's somewhat limited sometimes for folks with PTSD. All right, so we're going to launch right into criteria B. We're going to start with this video, and this is this patient's, in particular, his experience with intrusion symptoms. All right, so that's all we're going to do for his story. What he didn't tell you is that he has a lot of combat trauma. And why he says helicopter is because that brings a lot back, and that he really struggled with nightmares and trauma after that external cue of that wreck on the highway. So criteria B, so it's one or more of the following. So it's recurrent, involuntary, intrusive memories, distressing dreams, dissociative reactions like flashbacks, and also intense or prolonged psychological distress or physiological reactions. So that would all meet criteria for criteria B. And this is from internal or external traumatic cues. So let's talk about the intrusion symptom circuit. Again, don't get scared by the picture of the brain here. I'll talk you through it. But traumatic event is persistently, or things that are persistently involuntarily re-experienced. The theory is that it's the failure of the cortex to inhibit the limbic system, and we kind of get with that theme a lot today. When a PTSD patient is re-experiencing in the moment, there is decreased activity in the anterior cerebral cortex. So rostral is a little R, that's what that stands for. There's also decreased activity in the inferior frontal cortex, which is the prefrontal cortex right here. And both of these areas control attention, emotion, and arousal regulation. At the same time, there is an increased activity in the insula, which controls interoception and bodily awareness, basically making that flashback experience seem real and in the moment. So going to the rodent model here, what makes these intrusive symptoms hard to control is their deficits in fear extinction. In classical conditioning, fear extinction is a gradual decrease in a fear response to a conditioned stimulus when it is repeatedly presented fear extinction is a gradual decrease in the fear response to a continuous stimulus when it's repeatedly presented without an aversive cue. So for example, a rat with intact fear extinction that has a good preformed conditioned fear response to a tone that is usually followed by a shock will repeatedly have to be presented with this same tone without the shock in order for the fear response to be extinguished and the tone to no longer create a fear response. Folks with PTSD have trouble with this. Intact fear extinction involves formation of a new memory, which in this case will be a new memory of the tone without the shock, so that the fear response is inhibited when the tone is presented. So possibly contributes to this deficit in fear extinction is that PTSD individuals have a smaller ventromedial prefrontal cortex, which in rats is made up of the prelimbic and infralimbic area, those PL and the IL up there, and hypoactivity in this area. It's been demonstrated that in rat models where the infralimbic area, the IL area of the prefrontal cortex is not functional, thereby making fear extinction memories unable to be formed. So folks with PTSD, they're shown things every day that don't really have a threat, but that fear extinction is not really drowned out, and they still have the same fear response over and over again. So moving on to avoidance symptoms. I don't know if this video is going to start at the right time, but if it doesn't, just go straight to 3 minutes if you can. So this lady's going to talk about her experience with that. That's fine. So sorry to cut her off again, but we're going to move on to what the actual criteria is. So she's talking about clearly avoidance, she said it, but it's one or both of avoidance of distressing internal or external cues from past traumatic events. So actually going into the avoidance system circuit again, by definition, a cue or context that is avoided cannot be extinguished. in a normal fashion, and avoidance is central to fear extinction deficits. Trauma-focused therapies focus on exposure to past trauma in a controlled, safe setting. Active avoidance in humans is correlated with decreased activity in the anterior cingulate cortex and inferior frontal cortex, along with decreased activity in the superior temporal cortex. Kind of extrapolating this to the rodent model, active avoidance in rodents has been shown that when there are lesions to the infralimbic cortex, again, that's part of the prefrontal cortex for this model, it releases inhibition of the central amygdala, thereby sending a signal to the nucleus accumbens, which is part of the basal ganglia, which is essentially a call to action, active avoidance. Corticosteroid release, you can see on the slide, corticosteroid releasing hormone has also been implicated in active avoidance in rat models. Interestingly, the propensity to pursue active avoidance versus its opposite, passive freezing, is heterogeneous across the rodent population and is thought to be a possible model for resilience. Talking a little bit more about passive freezing, we'll contrast this with active avoidance. It's interesting to note that the passive freezing response is related to specific subtypes of PTSD. If you look in the criteria in the DSM, it has this dissociative subtype, which is either derealization or depersonalization. In effect, this type of PTSD is how a person deals with the trauma in a manner that is opposite to the non-dissociative reactions in classic PTSD. So you can tell that like the brain activity is actually opposite what it normally is. It involves increased prefrontal activity and medial cingulate cortex activity and decreased amygdala and insulin activity with no change or even a decrease in the heart rate when they're responding to a trauma. This is the opposite, again, of classical PTSD response. This model also fits with the DIT, which I don't know if you've seen Moon Knight. There's Stephen Grant and his Counterpoint. It's a great show. Not perfectly representing DID, however, in dissociative identity disorder, it exists on a spectrum of dissociation due to past trauma that includes, in addition to derealization, depersonalization, personalization, amnesia, and identity disturbance. Notably, it usually is in children, developed in children before the age of 6 to severe trauma. But in any case, the key point is that both active avoidance and passive freezing response to past trauma in PTSD specifically is maladaptive because the individual doesn't have any control over it. So a lot more can be said with that, obviously. We'll have questions at the end, but let's go into criteria D. So negative alterations in cognition and mood. And I certainly wanted to make sure that Vietnam veterans are represented here and not forget about them. So we're going to hear what they have to say. So great examples there of kind of some negative alterations in cognition and mood. When I look at this criteria, so there's 7 of them. You know, I kind of split it up with amnesia responses for the first one, and then the last 6 being kind of depressive symptoms. So again, going into the circuit here, what's going on in the human brain with this? PTSD patients frequently have inability to recall key features of a trauma. They have some memory fragmentation as well, which is thought to be impaired function of the hippocampus and reduced hippocampal volume. The hippocampus, like we said earlier, normally functions in memory encoding and consolidation and spatial memory. For people with PTSD, hippocampal activity is less. In declarative memory. So that's like memories and events that can be explicitly recalled. You kind of contrast this to non-declarative memory, which is kind of like riding a bike, things you can do from memory without conscious thought. This decreased activity also leads to poor ability to recall fear extinction, like we talked about earlier. So with this hippocampal inactivity or just decreased function or atrophy, there's certainly a lot of problems with that in terms of being able to work back through past trauma. A suggested mechanism of hippocampal atrophy is decreased BDNF and CREB1 due to both acute and chronic corticosteroid secretion and traumatic experiences. Brain-derived neurotrophic factor helps stimulate and control neurogenesis, also supporting survival of existing neurons. It's heavily active in the hippocampus and needed for long-term memory formation. CREB1, camp responsive element binding protein 1, in the adult brain also participates in neuroplasticity, learning, and memory. New evidence, though, supports that there's a hypothesis for this particular compound that may directly stimulate adult hippocampal neurogenesis. So I put a little slide in here. These are the different parts of the hippocampus that are affected. You can read off the slide, but impaired neurogenesis in the dentate gyrus, decreased long-term potentiation in CA1, and dendritic retraction in CA3. So if you ever get a test question on that, where does adult neurogenesis take place, you can answer it based on the hippocampus, and that's also dysfunctional in PTSD with some patients. So let's talk about the last 6. So again, like I said, these are basically depressive symptoms. You can couple that with negative self-beliefs, negative beliefs about the world in general. Patients with PTSD tend to have trouble voluntarily controlling their emotions. And this is correlated with decreased activity, you guessed it, in the prefrontal cortex. In a study where there are negative pictures presented to PTSD individuals in both trauma-exposed but not having PTSD and non-trauma exposed controls, PTSD individuals have poorer ability to downregulate emotional reactivities to negative pictures than either one of the controls. I think it's worthy to mention that not everybody that experiences trauma develops PTSD, but certainly the ones that do have a hard time regulating their emotions, especially in this study when it was based on trauma-focused trauma pictures. In another study with negatively valenced but not traumatic pictures, so just negative pictures, these pictures elicited emotions of sadness and anxiety in individuals with PTSD and were associated with decreased anterior cingulate cortex and thalamus activity, which are patterns seen when personally triggering traumas are presented. Some generalization there as well. In terms of anhedonia symptoms, an inability to experience positive emotions, PTSD patients appear to have deficits in reward processing. So reward processing is basically two parts. The approach phase, where rewarding stimuli are sought out, and then the actual consumption phase, which is pleasure that is experienced once the reward is required. Both phases are affected in PTSD. This corresponds to hypoactivity in both the striatum and prefrontal cortex in response to rewarding stimuli for individuals with PTSD in comparison to controls. And if you remember, the striatum is part of the basal ganglia, so there's a lack of activity there, a lack of seeking out a reward. For restricted range of affect, or commonly termed emotional numbing, and I think Rick, that guy in the last study, had mentioned that, there's decreased prefrontal cortex activity that is correlated with emotional numbness in both positive and negative scenarios, so inability to experience extreme positive or negative emotions at times. Alexithymia, which is difficult recognizing and naming emotional states, so poor emotional insight. There is decreased activity in areas that provide a visceral sense of emotion and emotional regulation, which are the prefrontal cortex, again, the anterior insula, during instances where PTSD symptoms are triggered. All right, so we are on the criteria E, alterations in arousal and reactivity, and let's listen to what this gentleman has to say here. So pretty good examples there for criteria E alterations in arousal or activity. And you can kind of think of these as anxiety with poor impulse control and sleep deficits. So specifically when we talk about aggressive behavior, individuals with reactive aggression and PTSD have activation in the amygdala and the perioccipital gray area. We haven't talked about that structure, but basically it's a critical role in motivation for behavior and behavioral responses to threatening stimuli, so similar to amygdala. And activity in the locus coeruleus. That's another great test question in terms of norepinephrine control, which is linked specifically to aggression. They also had overall failure in top-down control, which included reduced activity in the prefrontal cortex again, increased activity in anterior cingulate cortex, specifically related to angry rumination. Dysfunction, and also dysfunction between the orbital frontal cortex and the basolateral amygdala was also implicated, specifically in impulsivity. I don't think that's hard to figure out from that one. Moving on to a couple more of these symptoms, again, using the RAT model there. The general arousal and reactivity circuit is associated with reduced activity in the prefrontal cortex and ventral hippocampus, and hyperactivity in the amygdala and the bed nucleus of the stria terminalis, which is basically a continuum of the amygdala. For hypervigilance, the CNS network is the dominating processing mode network, bites the default mode network for folks with PTSD, and it's basically they're not coming back to a resting state. The CNS network is primarily composed of parts of the limbic system, so anterior insula, dorsal anterior cingulate cortex, and amygdala. And is involved in coordinating responses to stimuli, as you might guess. You can contrast the CNS network to the default node network, which is network that responds to wakeful rest. So a lot of times folks with PTSD don't quite get back to that. For concentration deficits, there's evidence that subtle deficits in executive function predispose a person to PTSD, but regardless, PTSD patients struggle more during taxing inhibition related tasks and increased prefrontal activity during sustained attention tasks. This is thought to be associated with attentional hypervigilance in PTSD and inability to inhibit during more demanding tasks. And it's not hard to kind of conceptualize that. If you're constantly hypervigilant, you have less reserve to be able to concentrate on tasks, especially inhibit things. So that rounds out our criteria B through E, but there are a couple more here. I just want to make sure that we mention it. Duration for PTSD is obviously 1 month. Has to have a significant distress or impairment in social, occupational, and other important areas of functioning, and then the service not contribute to another physiological problem. There are some specifiers, as I mentioned earlier, dissociative symptoms, and then certainly delayed expression. I watched one video for a gentleman, a Vietnam veteran, that didn't have any symptoms really that affected his life until he saw the Twin Towers fall in 9/11. So that was, for him, that was very much a triggering event for him. So he'd be definitely delayed expression. So let's talk a little bit about therapy here, and just in terms of like what's effective. I went a little too far. So there are a couple FDA SSRIs for PTSD, Zoloft and Paxil. I also found a study on the chronic fluoxetine that actually states that it remodels dendritic spines in the hippocampus, enhancing subsequent fear extinction and decreasing fear memory generalization. So that's helpful to know. MDMA assisted psychotherapy just finished a phase 3 trial in 2021. A quote from that is, compared with manualized therapy with inactive placebo, MDMA assisted therapy is highly efficacious in individuals with severe PTSD, and treatment is safe and well tolerated. Moving on to ketamine, there have been some good results in that. There's RCT in 2021 showed evidence of efficacy in repeated ketamine infusions in reducing symptom severity, but not really a remission of symptoms. And then stellate ganglion block, you probably heard about that before. There was a lot of unblinded, uncontrolled case series that showed a lot of really positive results, but the RCT that came out was kind of disappointing, inconclusive, neither confirming or refuting those prior findings. So that's kind of an update on things other than therapy. When you talk about trauma-focused therapy, which we'll do now. I'll reference again that article I had at the beginning, that 2021 systematic review of the neurophysiology of trauma-focused therapy. They stated that there's 3 components, and I think we kind of leave the first one out. Motivation to get better and part of the patient. I mean, trauma-focused therapy, we'll see in a second, it's not easy. Exposure to the actual trauma, and then re-scripting. So specifically, reconsolidation is a process where fear-based memories can be retrieved and are malleable and receptive to change. This period of malleability lasts about 6 hours, and this ability to add new material or re-scripting as one of the necessary components to a memory is referred to as an evolutionary adaptive update mechanism. So evolutionary, that's something that we have kind of built in to be able to overcome trauma. At least that's a thought. And this positive change can last from 1 year or even longer. I'm a glass half full kind of guy, so I say exposure therapy results in response for 60% of patients. You can see at the bottom it says 40% doesn't work. So that's my interpretation of that. But let's look at this. So this is from that systematic review that I referred to. The 2 ones in terms of trauma focus was trauma focus CBT and EMDR. They used fMRI data with the blood oxygen level dependent signals, and this is the areas that were activated during this particular therapy. So the hippocampus, the prefrontal cortex, and the anterior cingulate cortex were things that were activated in those therapy modalities. The next one was deactivation, and it's basically deactivates the limbic system. So amygdala, thalamus, and the hindbrain. Hindbrain basically refers to functions that are fundamental to survival, like respiratory rhythm, motor activity, sleep, things like that. Dr. O did ask me to mention one thing, because there's been some new data come out. There is one caveat that with this new data, there have been some studies that show that for some people, non-trauma focused therapies are almost equivalent to trauma focused therapies. So there's probably some component of re-scripting and exposure that goes on in those kinds of therapies. But I think as long as we stated those components in terms of exposure, re-scripting, and positive motivation by the patient, I think would be successful. So one of the last points here, I just want to show, this is a particular patient's experience with trauma-focused therapy. I think that's a perfect patient representation of trauma-focused therapy. And I've heard the analogy of a skateboard on a ramp, where it just kind of goes back and forth for like about 48 hours after having a trauma-focused therapy session until it kind of rests at the bottom. And that's kind of 2 days he's talking about of continued trauma for him. So I will play this last video and we'll go over some objectives that we covered today. So this is going to be 3:30 on the video if it doesn't play. No, I'm sorry to put you on the spot again. I love what you had to say. So couldn't say it better myself. Yeah, it's just kind of a realistic way to picture trauma-focused therapy, and folks that are reaching out for PTSD. Certainly part of our job is to help people not avoid and help people get the help they need. So not only being therapists ourselves, but also with medication management, everything that we can provide that's in our quiver. So for today, we define what trauma is based on criteria A. We identify the basic theory and effects of trauma on the human body, explaining specific neural tracts related to specific symptoms based on the actual criteria from the DSM-5 TR, and we related why specific modalities of treatment are effective for PTSD. Before any questions, I want to thank some folks. These are my two brothers up top, and my parents at the bottom. So I wouldn't be here today without them. And certainly my lovely wife, I wouldn't be the person and the man I am today without her. So thank you so much for their support. And I lost my mom in November this past year. Just want to say thank you, Mom. I know you're watching, and I think that is it. Any questions at this point? Oh, here's my references, sorry, and feedback. Up top.
Thanks for your presentation. I love that you went into all the neuroanatomy of everything. When you came across, in your research, did you come across anything that would point to the existence of intergenerational trauma and how that is passed down?
I didn't I don't have a specific study in my references, but I did see it. And that kind of goes back to, they related basically ACEs scores that are high across different generations. And certainly I didn't go back into that in terms of history that may predispose someone for PTSD, but certainly a family system that someone comes from would predispose someone to PTSD, but I don't have any data that would specifically say that.
There was a rat study where they were able to teach rats how to be afraid of snakes, and the following generation was afraid of snakes. It's epigenetic changes.
Very cool. Thank you, Dr. Bell. Yes, ma'am.
In your research, do you think that we're moving toward a path or a way where we could create a more resilient fighting force? So, like, are we getting to a point at some point in medicine where we could scan somebody's head and be able to determine this person has a higher chance of PTSD than this person, so we don't deploy or we don't take this person?
I mean, I think you could probably do that now with functional MRI and put specific tasks with folks. If there was a way to actually scan their brain while you were doing it, I think that's a interesting topic that I don't know if we ethically could pick folks out like that, but I think there's a possibility in the future that could certainly happen. Because the fact of the matter, what's happened to you in the past, and maybe more importantly, how your brain reacts to traumatic situations can certainly predispose you to whether you're going to be, not that you can't predict the future, but maybe whether they would develop PTSD. So. Yes.
Hi, Second Lieutenant Anthony White. I'm a medical student here. I was just curious, based on some of the neuroanatomy that you got into with, real physical changes going on in the brain, do you know if phantom limb pain is a higher occurrence when it's comorbid with PTSD?
It certainly makes sense, but I did not find any data that would show that. But I think somatization in general, not having control of those parts of the brain in terms of, let's say, the insula, for instance, certainly could lend yourself to have a somatization or even something like phantom limb pain. But I didn't see anything specifically that said that. Yes, sir.
Yeah, thanks for the great talk. I think it's easier to diagnose PTSD when there is like a clear big T criteria and any kind of trauma, but then where, you know, I find it's a bit more of a gray area is maybe someone who does have little T's, but like a bunch of them kind of collected over time. Is there anything you found in your research, or maybe even anecdotally from your experience, kind of working with that? And like you feel like even in those cases, probably a lot of the neuroanatomy you mentioned probably applies.
Yeah, I mean, I think even if someone doesn't meet that big T criteria A trauma, they certainly can be affected by things. That's kind of alluding to that in the beginning, and I think if you felt that was something that they were having those same symptoms and maybe it wasn't criteria A, then maybe trauma-focused therapy or just treating it like trauma in general would be effective. And I don't see a problem with that. I've had one patient I've done that with, that it wasn't necessarily sexual assault or it wasn't necessarily bodily harm or a threat to their life, but it was effective. So.
Left time for one more question.
Yes, sir.
Any reflection? I know that we are still trying to figure out the anatomy and the physiology piece. Still, fairly early, and one of the challenges is the heterogeneity of our diagnostic processes, right? So, if you have the same illness versus person B who has completely different criteria, then it is really hard to then say that you guys have the same disorder, and sort of the phenotype of that in terms of, behavioral observations, but you have the same disease, right? And so, as you were researching this, was there any discussion on how researchers are coping with that heterogeneity?
Yeah, that's a great question, sir. I feel like maybe I did at some point when we were going over this. I think the reason that's hard in PTSD is because there's so many symptoms and there's so much overlap. You think those last two criteria, I mean, it's a ton of anxiety symptoms, a ton of cognitive function, it's a kind of a depression as well. So I think I didn't see any specific modalities that I can think of that was like, hey, this particular type of PTSD would be helpful with this type of treatment. It was kind of a blanket response of trauma-focused therapy. And I think a therapist or a psychiatrist that is also a good therapist would have to tailor that in their personal setting. I didn't see anything that was like, hey, this is what's helpful. I will say that the MDMA study with severe PTSD was helpful just in terms of like the severity of it as opposed to maybe the type, because it would allow them to access the trauma as opposed to just not being able to interact at all. So that's a general question, a general answer, but I didn't find anything else specific. So.